man with metabolic acidosis. 52-year-old man, known alcohol abuse, is brought to the ER in stupor. He's vomiting and complains of a vague abdominal pain. On exam, blood pressure is 110/68, temperature is 99, pulse is 100. He's disheveled, neck is supple, liver is palpable. No other findings are positive. Sodium is 145, potassium is 4.5, chloride 99, bicarbonate of 10, BUN of 37, creatinine of 1.8, glucose is 92. His anion gap is 31, his ketones are 1 to 4. Serum osm is 325, lactic acid is 3.5. ABG shows a pH of 7.2, PCO2 of 24, PO2 of 100. His urinalysis has a pH of 5, has 6 to 10 white cells, 2 to 4 red cells, has a few granular casts and some calcium oxalate crystals. The best explanation for his metabolic acidosis is metabolic acidosis of renal failure, salicylate intoxication, ethylene glycol intoxication, lactic acidosis, or alcoholic ketoacidosis. Okay, very good. Ethylene glycol intoxication is the correct answer. And so if we look at the other possibilities, metabolic acidosis of renal failure is unlikely in someone who has a creatinine of only 0.8, so 1.8. So this is, even if this were chronic, it would not explain this degree of acidemia. In acute renal failure, it hasn't been long enough to cause that. Salicylate intoxication is something that we could suspect. The classic combination is metabolic acidosis with a respiratory alkalosis. In this case, the PCO2 is exactly where you'd like to be, so there's no second component to the disorder. But more importantly, this patient has a high osmolar gap, has a high osmolality much greater than the calculated osmolality, so we would not think of salicylate as causing a big component of that. Lactic acidosis we cannot explain. There's an ion gap of 31 with a lactate of only 3.5, so this is certainly not the major explanation for the acidemia. And the same thing for alcoholic ketoacidosis. Even though serum ketones are not great at detecting this, because patients with alcoholic ketoacidosis produce a lot of beta-hydroxybutyrate, and the ketones, when measured without being the measurement of beta-hydroxybutyrate, they don't capture a lot of that. But at 1 to 4, it would be very unlikely to do that. Furthermore, it would not explain the osmolar gap that the patient has. So the answer is ethylene glycol. The patient has the right profile for that. He has known alcohol abuse. On his laboratory testing, he has very high anion gap with an osmolar gap, and then to seal, he has calcium oxalate crystals in the urine, which is a very common finding in patients with ethylene glycol intoxication. So for patients who have a high anion gap, high osmolar gap acidosis, the three most important causes that you need to think about are ethylene glycol, methanol, and propylene glycol. So for ethylene glycol, the cause of the osmolar gap is the ethylene glycol itself, is the alcohol, but that's not what's toxic, and that's not what causes the anion gap. The toxicity is from the breakdown of ethylene glycol, and by especially the deposition of glycolic acid and oxalic acid in the kidney. So the anion gap is caused by glycolic, oxalic, and hippuric acid. In methanol, again, the osmolar gap is caused by the alcohol, but the anion gap is caused by its degradation, and mostly formic acid, but also lactic acid. And in propylene glycol, then the anion gap is caused by a combination of L-lactic and D-lactic acids. For ethylene glycol intoxication, it's usually present in antifreeze and in some solvents. The clinical presentation is often triphasic. So initially there's CNS depression, which is the toxic effect of the alcohol itself. Patients get depressed, get drunk from it. This is usually accompanied by some level of hypertension. And then as breakdown of the toxic alcohol occurs by action of the, usually if they are drinking at the same time, it's after the alcohol is gone, so the alcohol dehydrogenase is now no longer with the competition of alcohol, so it starts breaking down the toxic alcohol, and then you start seeing the development of acidemia, ultimately cardiovascular collapse, and then the third stage is the stage of renal failure due to a lot of oxalate nephropathy. The diagnosis is high anion gap with high osmolar gap. The calcium oxalate in the urine, as I mentioned to you, is something important to think about. They often have leukocytosis, but now, for example, in our ER, the patient, we don't have to suspect this for too long. They just send a sample for a toxic alcohol screen, and we have the answer pretty quickly if we suspect it or not. The treatment is a combination of several things. We need to treat the acidemia, and that's often by expansion of extracellular fluid volume using an isotonic sodium bicarbonate concentration. But the key to prevent toxicity is to decrease the breakdown of the toxic alcohol while it can be removed. And the way that you can do that is by inhibiting alcohol dehydrogenase, which used to be done in the old days with alcohol infusions, but now can be done much more simply with the use of fomepizole. And I think most emergency rooms keep fomepizole in store, so that you prevent the conversion into the toxic elements and allows either the kidney to excrete what's remaining of the toxic alcohol, or if renal function is already impaired, that it can be removed through dialysis. There's also some value of increasing the conversion of glyoxylate to glycine. This is because glycine is not toxic, whereas glyoxylic acid is, and you can do that by a combination of pyridoxine and thiamine. So infusing those vitamins is part of the treatment. And then, as I said, removal of the toxic metabolites, which can be done with dialysis, in most cases hemodialysis. We do that in patients who have severe neurologic changes, and obviously in patients who have severe acidemia or established renal failure. But in patients who are caught early in the presentation and are doing, especially those who regret having taken the stuff, come in, they're still doing pretty well and renal function is preserved, you may be able to get by just giving fomepizole and forced diuresis to excrete this through their own devices without needing dialysis. Methanol is present in windshield washer fluids, also in antifreeze. The presentation is different. There's a component of abdominal pain. There's a retinopathy related to it, and a classic, fortunately not that frequent presentation of putaminal necrosis. The treatment is essentially the same, absolutely the same approaches as done for ethylene glycol. And finally, propylene glycol toxicity. Remember that propylene glycol is a diluent for several drugs. The ones that we give enough that can cause propylene glycol intoxication, by far the most important is IV lorazepam when used in high dose drips, especially to treat alcohol withdrawal. Now, you can get enough, if you use a lot of etomidate, you can see that, so I've seen anesthesiologists reporting on that. Most of the other drugs, they have it, so Bactrim, Valium, nitroglycerin, you just don't give enough of the drugs to cause propylene glycol intoxication. All the cases that I have seen have been with IV Ativan treating, in large drip doses, treating alcohol withdrawal. The treatment is removal of that, and unfortunately, because very often they have acute renal failure, dialysis is part of the management as well.